अदरवाइज वो अननेसेसरी की आवाज आएगी. अदरवाइज वो अननेसेसरी की आवाज. I am muting all. Dr. Uma Shankar and Dr. Abhir, you please unmute yourself. Abhir, you can share your screen. I'll before that I will let me do our rituals. So welcome to our this evening digital seminar organized by Dermatological Consortium, and today's speaker is none else than Dr. Abhir Sarswat. Dr. Abhir Sarswat is well-known personality, and I'll request Dr. U.S. Agarwal to kindly introduce Dr. Abhir Sarswat.
Good evening, everybody. I welcome you all today, especially on the eve of the Doctor's Day. And it is my privilege and my pleasure to introduce Dr. Abhir Sarswat, consultant dermatologist, Industry Clinic, Lucknow. He has passed his MBBS from AFMC Pune in 1995. He did his MD from PGNAR Chandigarh 1999 and did his DNV and MNMS in 2001. He is a well-known figure, academician, speaker. Everybody knows him very well for his lectures. He is attending and delivering lectures in many national and international conferences. To summarize few of them, he has around 70 publications, 46 in the international journals and 24 in the Indian journals. Numerous invited lectures and oral papers presented at national and international conferences. Member IDBL Academy 2010 to 2012. Present affiliation is a private practice since 2002. National Coordinator Specialist Test Group Psoriasis IDBL in 2017-18. Chairperson IDBL Task Force Against Tropical Steroid Abuse 2020-21. His interest subjects are psoriasis, atopic dermatitis, alopecia, psychokinetics disorders, and dermatopathology. Today, he will be enlightening us on what is new and what is the recent advances in the treatment of the psoriasis. Welcome, Dr. Abhir Sarswat.
Thank you very much, Dr. Agarwal, for the kind introduction. I will start sharing my screen. I hope my screen is visible.
Yes, please.
Yeah. So, thank you very much. First of all, I would like to thank Dr. Dinesh Mathur and the whole academic group for inviting me for today's talk. I thought initially I'll do the usual thing about what's new, various new drugs, the latest trials in psoriasis. But I thought better of it, and I'll do it in a slightly different way today. I will try to tackle just three different aspects and three different points in psoriasis, which are relatively lesser understood and for which more and more evidence and information is coming, and which we need to recognize to be efficient in managing psoriasis in 2021. So I will present this in three short parts of 10 to 15 minutes each. So what is new in the initial assessment of psoriasis? So in the history-taking part of psoriasis, when we initially talk to a psoriasis patient, examine him, the psychosocial aspect, the psychological aspects are something that are sometimes missed by many dermatologists or not given enough importance, or the real extent of their involvement and their importance in psoriasis is not understood by many dermatologists. So on that aspect, I will talk about what the recent knowledge tells us about the psychological aspects of psoriasis and how to integrate that into our management of psoriasis. Then when we come to the examination aspect of things, this is relatively better known than the psychological aspects, but still it requires a lot more emphasis from our side so that it becomes second nature for us to consider psoriasis as a disease, a bunch of diseases, or a spectrum of diseases which have a common underlying inflammatory pathology. So we'll discuss comorbidities in short. And then I thought one of the examples of the newer therapies in psoriasis, and I think a group worth discussing apart from biologics is the JAK inhibitors, because it really illustrates nicely what are the pros and some of the cons of the direction which psoriasis therapy research is taking, and how we can better understand and integrate these therapeutic agents into the treatment of psoriasis. So first of all, I will talk about the psychological aspects of psoriasis. Now, most sufferers of psoriasis are not able to express how psoriasis affects them, except when the psoriasis affects some famous authors or poets or literateurs who are able to express themselves very well. And one such person was John Steinbeck, the famous American author of the late 19th and early 20th century, early to mid 20th century. He had severe psoriasis from childhood, and he wrote eloquently about this in various magazines, most commonly a famous series of essays in the New Yorker magazine titled At War with My Skin. And he writes eloquently, and if we read these essays, we realize what a psoriasis patient goes through, what kind of stigma, what kind of psychological problems he faces. In one of the pages, he remembers when he was in school in third grade, his teacher rummaged in my hair and said out aloud, "Good heavens, child, what's this on your head?" And then he faced systematic but very subtle discrimination throughout his school age. Then again, he remembers that the look on his mother when she thought he was not looking, look on his mother's face when she thought that he was not looking, as if she had laid an egg, which, when candled by the government, had been found to be rotten. And he wrote very eloquently about this: puddles of flake form wherever I rest my flesh. Each morning I vacuum my bed. My torture is only skin deep. There is no pain, not even itching. Although, as an aside, we know that more than 50% of psoriasis is itchy, but still he did not have itching. But still, we lepers live a long time. He compares himself to a leper, and ironically healthy in other aspects. Lusty though we are loathsome to love, keen-sighted though we hate to look upon ourselves. The name of the disease, spiritually speaking, is humiliation. So he wrote eloquently. Not everybody, my point is, not all of our patients will talk like this or tell us what they feel. But we have to take it out, and we have to, more importantly, factor it into how we talk to them, what we prescribe, what we expect from them. And it's a very complicated relationship that a psyche has with a disease like psoriasis. It affects the basic causations and exacerbations are affected by the psychological aspects. We all know that stress is a positive factor. Adherence to treatment is extremely important. Psychological aspects can make the adherence close to zero. Quality of life is affected by psyche, we all know, then, and ultimately the psychiatric morbidity can affect psoriasis. And this is a bidirectional effect. It is well known that people who have psychiatric disorders have worse psoriasis. So pre-existing depression, anxiety, bipolar disorder, if they get psoriasis, it is usually much, much more severe than usual. And of course, conversely, people who have worse psoriasis have worse psychiatric disorders, higher intensity, higher incidence of psychiatric disorders like depression, etc., suicidal risk, anxiety. And the risk is greatest in younger patients. And you can imagine if you start having these problems at a younger age group and the risk is highest in that, then what a lifetime of suffering lies in front of you. It is also more in females and those with severe psoriasis. So this is the age group where we have to be especially vigilant and try to pick up any psychological problems or correlates of psoriasis and tackle them and factor them in. Like I talked about adherence, and there are several studies that show that adherence in psoriasis patients is as it is quite poor. 33% to 78% only. 33%, I mean, if we stop and reflect, it's 2/3 of our prescriptions are down the drain. Only 1/3 of them are acted upon properly. As high as 78%, but the more psychiatric morbidity, the lower this number becomes. Depression is much, much more important in poor adherence than anxiety. It has been shown that patients who are depressed are worse at following the treatment plan if they have a low level of trust or satisfaction with their doctor. And of course, many times we think that people who are of a certain income group or a certain education or certain ethnicity or occupation are more. Absolutely no influence. These are our inherent biases that we think that these demographic variables affect how badly a person will feel. So a completely uneducated, very simple farmer or a farm laborer might feel very, very bad about psoriasis, and someone very highly evolved may be able to completely ignore the psychological aspects of it. So we must not make assumptions on this because science has proven that these are not important variables. So this is just some concrete examples of the bidirectional nature. So this is with anxiety. There are multiple studies. I will not go through this whole list on the left side column, but there are multiple biological correlates of how anxiety worsens barrier function, immune mediation, stress related responses, and directly worsens psoriasis. And the various aspects of psoriasis like itch, lack of social supports, especially in female patients, disfigurement, this leads to anxiety. So in both direction, this vicious cycle works. So debilitating clinical symptoms are the main causes of mood disorders, although they are not the only cause. Isolation due to social stigma. And then in the next stage, there is poor productivity because they are not able to concentrate on their job. They are not able to hold a job. Employability is low. They face systemic discrimination, marital discord, poor family relationship. So both family life as well as work life gets affected. And then if we give them something that aggravates this, so iatrogenic depression caused by, for example, drugs like apremilast or retinoids can actually worsen this. I'm putting these examples here because we need to think when we start to write our prescription what the patient is likely to go through, and is our prescription going to make matters worse or better. Smelly, sticky, or inconvenient treatment to an already depressed or anxious patient might make him, never come back to us. The inevitability and unpredictability of relapse as it is there, and this can act as a powerful mood depressant in our patients, and we have to reassure them again and again that these are treatable, these are controllable. So this is what we have learned recently. There is this so-called cytokine theory of depression, which directly links systemic inflammation and increased cytokines that are increased in diseases like psoriasis, but directly have a direct CNS effect in causing depression. So it is not through some psychological impact, but actually the cytokines that are worsening or causing psoriasis can directly cause depression in the central nervous system. And these are some multiple examples of how depression exacerbates psoriasis, which I told you directly these cytokines, substance P, itch perception, the continuous sensation of itch, this exacerbates. This is heightened by depression, and thereby it exacerbates psoriasis. And of course, psoriasis leads to depression, we all know, because of various factors which we've already discussed: sleep problems, sexual problems, work problems, disfigurement, stigmatization, harassment. So, and of course, a maladaptive schemas, the continuous thought that, I have been wronged against and I'm abnormal, I'm not good enough. So bidirectional nature, just like anxiety, psoriasis, depression also feeds into the same. And there are shared etiopathologic mechanisms. These all studies have been done in the past 5 to 10 years that have shown that abnormal calcium homeostasis, concentrations of substance P, beta adrenergic function, high levels of pro-inflammatory cytokines, they are independently associated with depression also, even in the absence of psoriasis. So there are these shared pathways that are controlling both psoriasis and depression. This is just a pictorial representation of the same thing. And you see that the main cytokines that cause psoriasis are common to depression, that is interleukin 17 and TNF alpha. Of course, sleep and sexual disorders also have bidirectional relationships with psoriasis. Other psychological associations which we sometimes forget to ask about, we do ask about alcohol, but patients may be taking opium, they may be taking marijuana, they may be dependent on painkillers, they may be dependent on opioids or even NSAIDs for that matter. They may have somatoform disorders, skin picking, etc., which we may misinterpret as itching, and we may just give antihistamines and forget the patient may be having a somatoform disorder. Of course, personality disorders are also directly associated, although though they are slightly out of our domain, they would need a referral to a psychiatrist. So what is the magnitude of this impact? Are we making a mountain out of a molehill? The health-related quality of life impact of these various problems, mental problems, psychological problems, has been measured in several studies. They are comparable to diseases like cancer, chronic lung disease, hypertension, or diabetes. Depression risk is, compared to the general population, the odds ratio is more than double. The suicidality risk is almost 1.5 times. So it is a pretty significant effect, which we cannot afford to ignore unless we are going to accept poor treatment outcomes and poor patient returns to us. And of course, patients with stress respond poorly to therapy. This we sometimes don't realize. There is an intrinsically poor response to therapy in patients who have high levels of stress hormones or high levels of pro-inflammatory cytokines. Not just because they are forgetting to take the medicines, they intrinsically respond poorly compared to patients who are not psychologically affected like that. And the study on PUVA showed it very clearly. I'll go back to this. Patients with high chronic stress took almost 2 times the number of PUVA treatments to clear compared to patients who had low levels. This was a study probably done in England a few years back. And consistently, it has been shown what happens if you treat it. Now, all these problems are fine, but if we treat it, if we do psychotherapy, if we do pharmacotherapy for these problems, for depression, anxiety, etc., does it make a difference? Study after study has shown that definitely it makes a positive, favorable difference in their life, in the overall quality of life of the psoriasis patient, in the overall anxiety level of the psoriasis patient, in the overall depression level of psoriasis patient. Multiple studies have shown that this forest plot is towards the positive side, which favors the outcome, the intervention that we are doing, which is treatment of these psychological problems. So we must. Now, I will not leave this, address the question of whether we should be treating this ourselves or should be taking the help of a psychiatrist. This is entirely up to us. The important thing for us is that we have to identify, recognize, understand the magnitude, and then in turn do something about it. So they have, like I said, just to recapitulate, they have wide-ranging impact and correlation with psoriasis in both treatment-seeking behavior, right from the very fact of visiting a doctor for their psoriasis, then to the severity of disease, then to response to treatment, then to side effects of treatment, then adherence of treatment, and overall quality of life. All of these have an effect on psoriasis. So what can we do? Finally, please remember to elicit these factors at the very first visit. The simple question, how do you feel, often breaks the ice, and the patient then tells you what their mental status is. Consider these factors while counseling and deciding treatment. So please do not give any treatments which may exacerbate these problems. Understand their situation and then provide easy to do treatments or whatever they are comfortable with. Refer or treat them optimally. This is entirely up to you, whether you would like to treat them yourself or refer. And of course, keep assessing these comorbidities, mental comorbidities at each follow-up, and keep altering the treatment according to that. So this is just the first part. I will now talk about the other conventional comorbidities of psoriasis. Of course, this was also a comorbidity of psoriasis, the mental aspect of it, which is often missed by us. Now, why should we study comorbidities or the classical comorbidities of psoriasis? Because A, they provide valuable insights into our understanding of the disease, and also more concretely, they give potential new targets for therapy. And this is how new drugs are developed. And of course, they help us make better management decisions in terms of choice of initial therapy, being able to predict which patient will respond how well, so that we can anticipate in advance, we can give preventive advice, we can do a timely referral for potentially life-saving interactions if we recognize these comorbidities, and all of this can get a much better quality of life for our patients. So these are the classical comorbidities that are known to be significantly associated with psoriasis to various degrees: major cardiovascular events, obesity, diabetes, metabolic syndrome, hypertension, dyslipidemia, and this we have already discussed. The prevalences are quite variable, but the numbers are all similar. The hazards ratio or odds ratio are all in excess of 1 and going as high as up to 6. So 6 times, 5 times, 3 times the odds ratio. So this is what is the dose effect? How much does what aspects of psoriasis decide which patient will get? So multiple meta-analyses have shown that the main comorbidity, that is the life-threatening comorbidity, which is stroke, myocardial infarction, and any other forms of cardiovascular death, it correlates directly with the severity of psoriasis. So we must be very conscious about this in our moderate to severe psoriasis patients. But longer duration of psoriasis has also got a similar correlation, though it is slightly weaker. So patients who are bad only for 1 or 2 months in a year, and the rest of the year they may have 1 or 2 plaques or even going into remission, but this cycle has been going on for years together or decades together, have start to get a risk which approaches this risk of the very severe patients who are bad all the time. So this we must all remember. We should not think that only the patients who look very bad will have these outcomes. And this was a landmark study which was done on hospitalized psoriasis patients, which brought this out in a very, very stark way. So he studied patients who had no previous or current heart problems who were hospitalized for psoriasis. So they were severe psoriasis patients, but they had absolutely no history of heart problems. But when they were examined and tested for coronary artery calcification, they had highly significantly elevated calcification. The difference was so significant that the study was unblinded and terminated before the target number was reached, and the patients were quickly referred to cardiologists and internists so that their treatment could be started. They did not wait to stop the study. So this is something, this was done about 10 to 12 years ago, and this is what alerted dermatologists to what kind of risk these patients were facing. And what is the attributable risk to psoriasis, for example, for a risk of myocardial infarction over a 10-year period? About 6% of the entire risk, which is genetic, lifestyle, etc., is contributed by psoriasis alone. So this is not a small number. What are the pathogenic pathways? Again, like I was talking about depression, it has been shown that many of the same cytokines that are involved in the key pathogenesis of psoriasis, the Th17 arm of the immune system, the Th1 arm of the acquired immune system, they are involved in atherosclerosis and plaque formation. So most T cell forms, for example, if you look at atherosclerotic plaques, most of them have Th1 immune lymphocytes infiltrating them. Patients with acute coronary syndrome have very high circulating Th17 cells. And if you inject IL-17 into a blood vessel in an experimental model, it has pro-inflammatory, pro-thrombotic, plaque destabilizing, and cell attracting effects, all dangerous effects on the plaque fragments. So shared pathological pathways are there. So psoriatic inflammation also then conversely drives atherosclerosis. As we can see here, this is also bidirectional, like the psychiatric morbidity. Inflammation drives psoriasis, and once the psoriatic inflammation is there in the skin and the joints, it further drives atherosclerosis, thereby providing a positive feedback loop. And this has been shown by several studies, and the key factors linking psoriatic inflammation with atherosclerosis are insulin resistance and endothelial dysfunction. There are several studies that show that insulin resistant and endothelial dysfunction act as the basic pathogenic link between psoriasis and cardiovascular disease. Which brings us to diabetes. And we all know that India is the diabetes capital of the world. We have the highest load of metabolic syndrome and diabetes in our patients, and there is very strong correlations with type 2 diabetes and psoriasis. Again, systemic inflammation has been characteristic of both diabetes and psoriasis, and the association is probably due to a combination of common lifestyle factors which contribute to psoriasis pathogenesis. We know that alcohol, tobacco, stress all aggravate psoriasis, They all cause insulin resistance as well. Of course, shared genetic predisposition, the shared same kind of genes that lead to a pro-inflammatory psoriatic state lead to insulin resistance as well. And of course, once inflammation occurs into the system, it worsens both of the things equally. And this was striking proof that if you control diabetes, so this was a very small study published 2 years ago in a Chinese journal, but it showed that patients of type 2 diabetes, when they were given liraglutide, which is a glucagon-like peptide analog, for their diabetes for 16 weeks, the PASI decreased significantly, the DLQI decreased, and all their metabolic parameters also started improving just by controlling their diabetes by giving them liraglutide, which is a GRP analog. So treating diabetes will improve psoriasis. Controlling psoriasis very well will improve glycemic control and metabolic syndrome parameters. So this is very clear-cut proof, although it is not there throughout all therapies or throughout all kinds of patients. There are several studies that show that the effect is not very strong, but conceptually it is important to understand that the links, underlying pathogenic links are there. And just like the atopic march that we read in atopic dermatitis, where children get atopic dermatitis, then as they grow older, they start to get food allergies, nasal allergies, ultimately end up with asthma. Similarly, this march has been proposed for psoriasis, where systemic inflammation leads to both psoriasis and insulin resistance, which causes endothelial dysfunction, atherosclerosis, and various aspects of that, cardiovascular morbidity and mortality. And of course, obesity feeds into this. Very interestingly, obesity, not just through its deleterious effect on the heart and on blood sugar control, directly obesity also affects psoriasis. Obese individuals have been shown to have higher transepidermal water loss, impaired barrier function, delayed type hypersensitivity. So there is something in adipocytes in the subcutaneous as well as the abdominal adipocytes, which worsens inflammation, which worsens blood sugar control. And these are the adipokines, adiponectin. And once the fat becomes hypertrophic, it starts to act like an immune organ. As you can see, when there is very little fat, a lean person, there are very few cytokines. But when the fat increases, macrophages infiltrate and various types of leptin, resistance, interleukin-6, TNF-alpha start to get produced in the adipose tissue itself. And also dietary fatty acids also aggravate this whole problem through the NF-kappa B pathway. Obesity exacerbates IL-17 production as well, which we know is a key cytokine in psoriasis. So again, multiple ways in which obesity is affecting psoriasis. It is aggravating diabetes, aggravating heart disease, blood pressure, etc., but also directly causing inflammation and worsening inflammation. Dyslipidemia is one of the markers which links all these things. So even beyond the usual cardiovascular risk factors, decreased HDL is seen in psoriasis patients. So it's very, very important not to aggravate this and to treat it if our patients have this. Liver disease is so important because most of our patients are treated with methotrexate. And we all know that India is almost becoming the non-alcoholic fatty liver disease capital of the world as well, just like diabetes. If you do baseline LFTs in our psoriasis patients, you will realize very quickly that so few of them have a completely normal LFT. So mild liver disease is more prevalent in psoriasis patients, chronic hepatitis, alcoholic liver disease, and non-alcoholic fatty liver disease. And moderate to severe fatty liver disease, that is NASH, the actual steatohepatitis, exacerbates insulin resistance and ties up everything else also. It releases various kinds of cytokines and aggravates psoriasis. So this is also something which I think most of us are aware. We keep testing liver function tests, but many times we do not counsel our patients enough as to what to do about this, how to reduce weight, increase exercise, etc. Smoking, again, direct correlation with the duration and intensity of smoking with the incidence of psoriasis. And also, this is one parameter, one comorbidity that is linked with directly reducing the response rates of our treatment and also adherence to therapy. There are various other established comorbidities, which I will not go into because of paucity of time, but I will directly come to the nub of the thing. What do we do about this and how do we do it? So how do we evaluate and counsel patients with comorbidities? risk assessment, like mental status assessment, has to be done on the very first visit. We have to do a thorough history taking, including a family history and history of smoking, alcohol, lifestyle, and of course, diabetes, inflammatory bowel disease, etc. Basic examination, weight, height, so that we can calculate the BMI, waist circumference, and examine the joints and entheses, so that we don't miss the most important comorbidity, which is psoriatic arthritis. I have not talked about it today again because I don't want to, give a 2-hour long lecture. So this has to be done on the first visit and periodically thereafter. And based on what we find in this, we have to order targeted screening tests and referral if it is needed. And then comes the explanation part of it. Why we are doing this? What does it mean for our patients? If they do something about these comorbidities, what benefits can they expect in treatment? Everything needs to be clearly spelled out. Otherwise, they will forget it. They will not do anything about it. They will think that you are referring them to some physician for some ulterior motives. It's very important, like I said earlier, at a younger age, if you find severe psoriasis, then the lifetime risk of these comorbidities increases several fold. So it's very, very important to evaluate our pediatric psoriasis patients for these comorbidities. And again, so obesity screening should be done yearly using the BMI percentile. Fasting serum glucose should be done every 3 years in our pediatric psoriasis patients if they are overweight or obese, or if they have any of these following conditions, that is BMI is more than 85th percentile, family history of diabetes, any signs of acanthosis nigricans, PCOS, hypertension, dyslipidemia, or if there's maternal diabetes. And of course, fasting lipid profile should be done twice at between 9 to 11 years and 17 to 21 years. And ALT testing for patients, all those who are obese or have signs of insulin resistance, and arthritis review by proper examination and history. These guidelines are all available in this JAMA dermatology article. I think it's very, very important for us to remember them, because pediatric psoriasis, if we catch them early, we can really make a difference in their life. It can be literally be a difference of life and death and quality of life for these young psoriasis patients who have moderate to severe psoriasis, because mild psoriasis patients, let's face it, don't really come to us very frequently. And how does this translate into how we treat our patients? Again, if we remember all these things that our patients have, then we, for an obese patient, for example, weight-based dosing is much better. If you give the standard dosing of drugs that have a fixed dose, then we are likely to fail. So we have to give, for example, infliximab is better than adalimumab, because adalimumab is a fixed dose schedule, whereas infliximab is a per kg body weight drug. So they will respond better if you give them according to their actual body weight. But of course, remember that TNF-alpha inhibitors cause mild weight gain in patients to the tune of 2 to 3 kilos, sometimes about 4 kilos over a period of a year or so. So this we have to tell our obese patients that this weight gain is going to happen, but if they correct their lifestyle, then often they have a net weight loss in spite of the weight gain that the TNF-alpha is causing. Of course, patients who have cardiovascular disease should be given methotrexate, because there is some evidence that it may reduce metabolic syndrome, it may reduce cardiovascular morbidity. TNF-alpha inhibitors have also been shown to directly reduce the incidence of cardiovascular problems, and of course, lifestyle change. If they have dyslipidemia, we must remember that acitretin and cyclosporin can worsen it. Methotrexate may be a good idea. Secukinumab may be a good idea, because that actually improves lipid profile parameters. Hypertension, we all know, we have to avoid cyclosporin and other agents can be given. If patients have non-alcoholic fatty liver disease, or if they take alcohol, not only should we avoid hepatotoxic drugs, but we should remember that even with apremilast, we need to do LFT monitoring for these patients. And of course, if they have a history of malignancy, then we should be seriously evaluating the risk and benefit of giving them phototherapy. And of course, acitretin would be a good idea in these patients. If they are depressed or they have psychiatric or psychological problems, then apremilast should be avoided, because there is a black box warning. We all know it can cause suicidal ideation in severe depression. And of course, even some retinoids can aggravate depression, although it is much more common with isotretinoin than acitretin, but still we must be careful. So this is just in summary that we have to take all of these into our account, because this is not a disease in isolation affecting the skin. It affects the whole body, each and every system. And if we keep in mind all the comorbidities, elicit them, address them, and target and design our management according to their impact on our patient, then we'll be much more successful in improving the overall quality of life of our patients. So now for the final short bit about the JAK inhibitors in psoriasis. Why I chose JAK inhibitors for my focused discussion on therapy is that there are a lot of discussions already on biologics, and JAK inhibitors recently in India have come out at a very cheap price point, and I see a lot of prescriptions being doled out by dermatologists for JAK inhibitors, not just psoriasis, in various diseases, without really considering what these drugs are, what potentially they can do, what are the good aspects, what are the bad aspects of these. So this is just a bit of basic science to understand what we are dealing with. Please understand that the JAK-STAT signaling pathway is one of the most ubiquitously present signaling pathways in our body. Literally every system, every cell in our body uses this particular transduction system to transmit signals that our body is sending extracellularly into the intracellular machinery to switch on and off various genes to do various functions in the body. And these are basically signal transduction molecules which act as homodimers. So two JAKs get together to form a receptor, then a cytokine attaches to that, and then in turn, which receptor it is, which homodimer it is, which cytokine it is, decides that which of these STAT molecules will be dephosphorylated in the cytoplasm and what signal they will give to the nucleus and which genes will be switched on and off. So basically, it's just a switching system, signal transmission system, very complicated signal transmission system. You can imagine, if you understand a bit of basic maths, there are 4 types of JAKs, there are 7 types of STATs. So combinations of 2 of these, and then they can activate combinations of 2 or 3 pairs of any of these. So there are literally hundreds of possible combinations that can lead. So that is why there are various hundreds of different things that these receptors can do to our cells, which should make you understand that we tinker with this pathway in a very, very specific way, because there can always be very, very unexpected off-site effects, because it's such a ubiquitous, complicated pathway. Although we might sound very, very specific in saying, no, I am going to hit only JAK1. But you see that JAK1 is here in this receptor. It is here with another JAK in this receptor. It is here with another third JAK with a different receptor. Each one of them is activating different sets of STAT molecules. So it's not that if you're targeting this, you're having various effects down the line. And this is what it does. I've already explained this, the JAK-STAT dephosphorylation pathway. And these are the various inhibitors that we have currently. So as you can see, most of the current generation JAK inhibitors are not single JAK inhibitors. Only desertotinib, peficitinib, and also upadacitinib, which is coming into the market shortly, they are single JAK inhibitors. Otherwise, all of the others inhibit 2 or 3 different JAK molecules, including tofacitinib that we have in our hands. So this makes things even more complex. Just inhibiting one JAK was producing various different effects. If you are inhibiting 2 or 3 differently, and each one of them to different degrees, you can imagine how difficult it would be to actually predict what is going to happen to which system. And these are the downsides. So this is what I was talking about, the various inhibitions of various systems, because JAK is involved in formation of blood, in the control of lipids, in how much hemoglobin or how much RBCs are formed, in cancer prevention, in immunity against various kinds of infections. It can cause any of these problems. And of course, this one I've circled in red because this is a black box warning on all JAK inhibitors of thrombotic effects. And this we must remember. I'll talk about the side effects a little later also. But these are the first generation JAK inhibitors, out of which only tofacitinib is easily available right now. All of these are available, but mainly for anti-malignancy or rheumatoid arthritis, ruxolitinib, etc. But tofacitinib and baricitinib is going to come in very shortly. And this inhibits JAK1 and 3 much more than it inhibits 2, although it inhibits, as you can see, it inhibits all 3, but these 2 the most. Ruxolitinib is a specific inhibitor of 1 and 2, and oclacitinib is JAK1 only. That's so, as you can see, it is such a widely distributed signaling system. So it is being tried in tens of different diseases. Literally, the whole dermatology textbook is here in what is being tried for treatment with these various types of JAK inhibitors. Ongoing trials are going on in arthritis, spondylitis, vasculitis, Crohn's disease, uveitis, psoriasis, alopecia areata, atopic, everything is there. What about specifically psoriasis? Because IL-12 and 23, which are the key drivers of Th17 inflammation, they are JAK mediated in their action. They are very powerful, expected to have a very powerful effect against psoriasis. And tofacitinib has been studied in various trials, and the results are slightly better than etanercept. In fact, non-inferior to etanercept. So 40% PASI 75 response at the low dose and about 65% PASI 75 response with the high dose. But the high dose also causes a slightly higher incidence of relatively severe side effects, which is why it has not been approved neither by the US FDA nor by the Indian drug authorities for psoriasis, but it has been approved only for rheumatoid arthritis and psoriatic arthritis, that too in the lower dose. The higher doses are off-label for even arthritis. Trials of topical JAKinibs in psoriasis, therefore, are underway, especially ruxolitinib, so that these kind of adverse effects can be minimized. What adverse effects are we talking about? Number one is thrombotic events. So the risk is quite low, actually, especially if you give the low dose, but it is consistently higher than placebo in each and every study. Venous thromboembolism, DVT, stroke, there is a signal in every study that slightly consistently higher risk is there. So we must remember this, although it may be very unusual, but any patients who are already prone to these, we cannot give, or they are taking any drugs which make them prone to these, we cannot give JAK inhibitors. Cytopenias are again a rare but consistently encountered side effect. So we can never lower our guard. We have to keep testing the CBC in these patients every month and then every 3 months. Opportunistic infection are the main reason why they did not get approval from the drug authorities for psoriasis, because herpes zoster incidence, this is the commonest infection associated with JAK inhibitors, about a 6 to 7% incidence in most trials. Reactivation of TB, just like TNF alpha inhibitors, even rarely opportunistic infection like cryptococcosis, etc. But these are dose related. At the 5 milligram BD dose, the incidence is quite low, but at the higher doses, the incidence rises up. And of course, this is sometimes not highlighted by the companies who make these. There are long-term concerns of aggressive squamous cell and basal cell carcinomas. This is clear-cut 5-year data on ruxolitinib from rheumatoid arthritis that shows that these patients have higher incidence of very aggressively behaving squamous cell carcinomas and basal cell carcinomas. That signal is probably so far not seen with tofacitinib, but we do not know. We do not have long enough studies, which is why second generation, more highly selective JAK inhibitors are in the pipeline. Upadacitinib has shown excellent results in atopic dermatitis. It is being tried for psoriatic arthritis, although for psoriasis, trials are probably going to start once it gets approved for atopic dermatitis. But these are single JAK inhibitors. They inhibit only one type of JAK molecule. So hopefully they will have lesser off-target side effects. So upadacitinib is the number one, which is closest to the market. It is already available abroad, but all of the others are also in the pipeline. This is also type 2 inhibitor, which is the fourth type of JAK, and there is a specific inhibitor for that as well, which is probably going to come into the market, which works for psoriasis about as well as infliximab, no more than that. So to conclude, and this is my last slide, JAK inhibitors are new and promising therapies in psoriasis. They have different safety profiles from the existing traditional medications or even biologic medications. They are closer to TNF alpha inhibitors in the kind of morbidity that they can cause in terms of side effects, and also have peculiar side effects like thromboembolic phenomenon, so which we must remember, although they are quite low in incidence. Tofacitinib treatments are effective in psoriasis, but the approval is currently only for PSA, please remember. Newer and more selective JAKinibs are in the pipeline. Probably we'll have much more safety then, and we'll be able to use this category of drugs much more commonly in the treatment of psoriasis. Thank you very much.
Thank you very much, Dr. Abhir. It was indeed a very nice lecture on psoriasis. I'll request Dr. R.D. Mehta. Rajesh, can you unmute yourself and present a bouquet to the present a token of
Dr. Abhir, Good evening, everybody.
Just a moment.
It was a wonderful deliberation with the recent advances being inculcated in your lecture. And I think it's going to enlighten everybody around. People who are having ifs and buts before starting the treatment in your modalities of the armamentarium of the pharmacokinetics of derma would be really enriched with your experience and vast go through the literature. Thanks from PGNAR.
All right. Thank you very much. And now we will take some questions from the and comments. Dr. Agrawal, I thought that you were also working on some immunomodulators in psoriasis. Would you like to comment on that?
Yes. Please, thank you. Dr. Abhir, can you listen to me?
Yes, sir.
Yeah. What is your experience of using methotrexate? In how many number of the patient the response is not good? What do you feel that is it effective in 100% patients or it is not effective in many patients?
Sir, if I heard your question right, you are asking about my experience with methotrexate and the number of non-responders or poor responders, right?
Yes.
All right. Like everybody else, like every other dermatologist in India, this is the most commonly used drug by me also. I would say about 70% of my patients of moderate to severe psoriasis get a prescription of methotrexate, either alone or in combination with something else. It is the most excellent drug I think that we can have for psoriasis, but there are non-responders. There is definitely non-responders, and the more severe the psoriasis is, the higher the number of non-responders. If we are treating mild to moderate psoriasis or difficult areas of psoriasis like palmoplantar or flexural, the response to methotrexate, I would say, effective response, acceptable response is to the tune of 75 to 80%. But if we treat the worst kinds of difficult psoriasis in obese patients, diabetic patients, then the response rate falls to around 40% or so, 40 to 50% in my hands. More so because we are less likely to take the risk of giving them relatively higher doses of methotrexate because we know they have NAFLD, they have diabetes, they are likely to, or they take alcohol, so those kinds of things.
Excellent, sir. I think you are absolutely right because in the standard textbooks also it has been mentioned that the methotrexate is effective in 70 to 80%
Yes,
of the
of
patients.
course. But probably in last one and a half year, we were a bit hesitant in giving high doses of methotrexate, and we were more confidently giving Premalas. Methotrexate probably less than 10 milligram or 7.5 milligram can be comfortably given during the COVID era. What is your take on Abhir on that?
So methotrexate, in terms of the risk of getting COVID, it's not much of a problem. In fact, I was giving methotrexate as I usually would when the COVID first and the second wave were raging. But vaccination is a different matter. COVID vaccination, of course, we have to, the guidelines are clear. If the patients are on methotrexate, then they have to miss at least one dose after the vaccine.
At least 2 weeks.
After each of the doses of vaccine, they have to miss one weekly dose of methotrexate.
Yes.
But specifically, methotrexate worsening the outcomes of COVID is not there. It's perfectly fine.
Those who are already taking the methotrexate, it is all right. But starting new patients, methotrexate was a bit tricky.
During active COVID infection, yes, that we would of course want to avoid it. Yes.
Right.
Sarswat, you said you were using some combinations. Can you tell me what combinations you are using? You said in 70% patient you are using alone, and in others you are using combination.
Methotrexate combination. Some of my favorite combinations are with cyclosporin and apremilast. There is a subset of patients where I have started combining it with acitretin as well in the past 4 to 5 years. It's a very good combination as long as we just keep a watch on the liver function. The risk of additive hepatotoxicity is more theoretical than actual in this. Our textbooks will always warn us against combining acitretin methotrexate, but if you actually start doing it, you will find that the actual risk, if you're doing proper monitoring, the actual risk is not that great.
Okay.
Right.
So it's a very interesting aspect, which is I wanted to highlight also, because recently one paper has appeared in the IGDVL. I think you must have read this paper, IGDVL, combining methotrexate and cyclosporine. One
Yes,
article
yes.
has appeared in the April issue of the IGDVL, where they were combined the methotrexate and cyclosporine.
Methotrexate and
So we also
cyclosporin
get
is
an
a poor
idea,
man's biologic.
because the pediatricians are using combination of the six-mercaptopurine and methotrexate very frequently in treatment of the leukemias.
But now
Six-mercaptopurine
nowadays
is
the Delimumab and these
the
TNF
azathioprine is a
inhibitors,
prodrug
they have reduced the price a lot.
methotrexate. So we had one project where we combined azathioprine and methotrexate. As you said, there was always a warning of using it, and we were afraid of the side effects. But we had sufficient data and sufficient background of using it, because the pediatricians are using it very frequently, and similarly the rheumatoid arthritis also, they are using combination of the methotrexate and the risk of the side effect, they said, is not more than the when we use individually. That is why we started.
I would just like to ask about the Apremilast. How happy you people are with the Apremilast?
Can you
Just
hear me?
yes.
So that is why we combined methotrexate and azathioprine, and we did a controlled study in 3 groups, and we found that the combination will help in those patients who are non-responders to the methotrexate one. And second, the PASI score reduction is much faster than using them alone, and also the relapse is less and is less severe. So that is what our observation is. This is a preliminary study we did in the 100 patients, and the side effect is also not more than what when we use them individually. I don't know what is your comment about this, Dr. Sarwat. Abhir?
I have not combined these two drugs, and it's interesting that you have done this. I'll be happy to read whenever you publish it, and it's intriguing, interesting. Although I am a bit afraid of combining anything except steroids with azathioprine, because it is such an unpredictable drug. So many of my patients have developed pancytopenias, etc. After 2 years of taking azathioprine successfully. In the third year, out for no reason, out of the blue, their TLC drops to 200. So I've had 4-5 such patients, and this is a well-known behavior
How
of
much,
azathioprine.
how much time you get the CBC done in azathioprine patient? Because we give a lot in airborne contact dermatitis and other things.
Yes.
And normally after the initial the third day and seventh day, and then probably I have hardly touch wood not seen any side effect with the azathioprine.
I get it once in 3 months, sir. And I have been fortunate to pick up some patients who were perfectly healthy looking, and they had dangerously low CBCs. And I have lost a few also.
That we should always do. That we should always do.
I have unfortunately lost a few patients also who nobody made the correlation with their azathioprine. They went to the ICU and passed away because of life-threatening infections. Later on, when some relative came to me out of the blue, I realized that they would have happened because of azathioprine. So all these things do happen. Azathioprine is notorious for that. Very rare, but very unpredictable late cytopenias are something that azathioprine is known for.
Definitely, we should be cautious and getting
hello, Dr. Abhir. Hello, Dr. Abhir.
Dr.
Yes.
Abhir, Dr. Shakuntala is asking Dr. Shakuntala Lavasa. She's allergic.
Chandigarh. Yeah, a special handshake to you because of being from my institute, PGI Chandigarh. I am a pediatrician here, and your patients unfortunately come to me because I deal with the allergies also. And I would like to comment that this is one test which is absolutely abused in cases of psoriasis, because we know that some food they act as triggers, and some food they do have correlation. But the way the allergy test is being abused by just sending blood sample and handing over a confusing list to patient and increasing the cost of treatment further and confusion further. So I would just like to emphasize that they do come to us, but then we should not be tempted to unnecessarily offer this kind of confusing test. And I have I
Shakuntala,
don't
which
think that I have come
computing test
across
you are
any
talking of?
known
Allergy
literature
test.
where there is and a food allergy test. So I would say that, the patients, because they are so helpless and they don't know that it is the autoimmunity which is the main factor, and the food triggers can be, just a correlation. But I would say that, we being scientific and practicing evidence-based medicine, we should not be tempted to actually abuse the allergy test. So that is my one point. And of course, I mean, you know it much better than me that there could be certain food triggers. And of course, if the patient has definite correlation, then scientifically the food allergy should be tested rather than, just by remote testing of, doing blood test like, for food allergy. That is not recommended. And then second thing, I especially like that, the psychological aspects which you have emphasized, because in pediatric practice we have seen even school dropout children, because the children, they are sort of, they do not know how to express. But imagine a child who is, no other child is sitting with that child, and he's made a backbencher, and he is just discriminated. So that kind of thing is very important to my mind. And counseling and psychological aspects have to be dealt. And I really like that you emphasized and you devoted a lot of time to the psychological counseling. So if anybody has any, experience with the food allergy test, I would like to know. But in my experience, it has no value.
Well, Shakuntala,
These are my comments.
I
And
asked
thank
you
you very
I
much
asked
for
you to give
giving
a
such
lecture
an.
on that.
Yes, of course, ma'am. Point
Yeah,
well
yeah, I
taken.
am ready, Dinesh.
Shakuntala, I asked you to give a lecture on that, and unfortunately, at that time, probably your mother got admitted in ICU, and that was being so.
That way,
You are the best
was in
person to
ICU.
give a lecture. So prepare it, and we will have it in
Sure.
our PGNAR next time.
I am ready, Dinesh. I am ready.
Right,
And
right.
thank you very much for giving such an enlightening talk. And it's really, really very helpful.
Sure. So we all will be waiting when you say give us a date. We will be having. So thank you very much. And any other comments and query? Otherwise, I am going to close the meeting. Thanks a lot. Thank you very much. There was a good on this faculty link. Around 30 people attended, and on the YouTube, I could see around more than 250 people listening your talk. So thank you very much once again, and good night all.
Thank you. Thank you. Good night.
Good night. Good night.
Thanks so much.
Good night.
Thank you.